For those of you that don't know me, I'm Dr. Sathe. I'm a physical medicine and rehab specialist here at St. Luke's. I used to work at the ARC, and then last year I transitioned to outpatient director and have offices currently in Bethlehem as well as Allentown as part of the neurosciences neurology department. So that's going pretty well. Thanks so much for those of you that are attending and attending via Skype. So our talk today is on cervicogenic headaches and objectives. Let me see if this pointer works. Objectives are an introduction to what cervicogenic headaches are, a differential diagnosis, understanding when to refer, and an overview of the treatment for cervicogenic headaches. So let's start with how the name came about. A Norwegian physician, and I'm going to butcher this name, Dr. Ottar Sojastad, I believe is how you say it, coined the term cervicogenic headache in 1983. Prior to that, they were known as cervical headaches, mainly headaches originating from a cervical origin. How to define and classify and how to describe what a cervicogenic headache. The main forms of classification and the definition occurs through two big international committees. The first is the International Classification of Headache Disorders. They recently came out with a third edition defining cervicogenic headaches as headaches caused by a disorder of the cervical spine and its component bony, disc, and or soft tissue elements, usually but not invariably accompanied by neck pain. Then the diagnostic criteria, according to that same International Classification of Headache Disorders, third edition, goes into more detail. The criteria includes clinical and or imaging evidence of a disorder or lesion within the cervical spine or soft tissues of the neck known to be able to cause headache. So in many of the cases, imaging may be negative, where the clinical exam is more important. And we'll talk about that a little later. Causation of the headache is demonstrated by at least two of the following based off of this criteria. The headache has developed in a temporal relation to the onset of the cervical disorder or appearance of the lesion, or the headache has improved or resolved in parallel with improvement or resolution of the cervical disorder or lesion. Cervical range of motion is reduced, and the headache is made significantly worse by provocative maneuvers. The last criteria is that the headache can be abolished following diagnostic blockade of the structure or nerve supply of the cervical spine. So the second international criteria was actually headed by that Norwegian physician that helped coin the term cervicogenic headache back in, I'm not sure exactly when this group was formulated, but I believe it was the 80s and 90s. So the 90s criteria is listed on this slide, where headache symptoms are precipitated by neck movement or sustained awkward head positioning, can be precipitated by external pressure over the upper cervical or occipital region on the symptomatic side. The neck range of motion, again, is restricted. The pain is ipsilateral, located in the neck, shoulder, or arm, ipsilateral to the headache, that is. And it can be non-radicular or it can be radicular in nature. It's also confirmed by diagnostic anesthetic blockade. And the number 3, that point, the unilaterality of the head pain without side shift, that's kind of a key point in the cervicogenic headache international study group criteria, which is a little bit different than the other criteria which we went over on the previous slides. Now the next slide is the updated criteria, and I've kind of highlighted the similarities between the updated and the 1990 criteria. Again, the unilaterality without side shift is important for the headache symptoms. Pain triggered by neck movement, sustained in an awkward position, pain elicited by external pressure again over the ipsilateral posterior neck region or occipital region, ipsilateral non-radicular neck, shoulder, and arm pain, reduced cervical range of motion. And then there's these other ones here: non-clustering pain episode of varying duration, which can be fluctuating or continuous. The description of the pain in number 5 here is moderate, non-excruciating, usually of a non-throbbing nature. And that's different than most migrainous type of headaches, which patients describe as severe, excruciating, and throbbing in nature. So that I found was an interesting criteria difference. The other ones, number 6 and 7, I'm not going to go over. Those are similar to the previous criteria in the 90s. And then the other ones, which include female sex, head and or neck trauma, nausea, vomiting, ipsilateral edema, dizziness, phono or photophobia, blurred vision, and difficulties swallowing. These can also be difficult criteria because they can frequently be seen with migraines and other type of disorders too. So they added those criteria because they see them simultaneously in cervicogenic headaches as well. The ones in bold are really the ones that are necessary for diagnosis based off of this criteria, but the other points are equally important also. Okay, how common, how prevalent are cervicogenic headaches? So in the general population, it's estimated to be about 4.1%. Among patients with severe headaches, it's 17.5%. And among patients with trauma, especially a whiplash type of injury, it's estimated to be about 53%. And I read an article which I think was published in a sports nutrition journal, which seemed to say that it's more prevalent in certain type of athletes, especially weightlifters. The mean age is 42.9 years of age, and females are 4 times more likely than males to present with cervicogenic headache. So to review the anatomy, what pain generators in the neck refer to the head? So this will give us a better understanding as to why neck disorders or pathology can refer to the head. So there's several generators, which many of us know can refer to the head. The upper 3 cervical spinal nerves are one, cervical facet joints are another. The actual muscles of the cervical muscles can refer pain to the head. The intervertebral disc, specifically at C2, C3. The arteries, vertebral intracarotid arteries. Dura mater of the upper spinal cord or the posterior fossa, including the brainstem and the cerebellum, can refer pain. And lastly, fascia, ligaments, and tendon, which are highly innervated, can also refer pain to the head, especially the ones of the very upper neck or the ones that insert onto the occiput. Understanding pathophysiology, and this is what the proposed mechanism is. The proposed mechanism is convergence between afferent nerves innervating the head and afferent nerves innervating the cervical spine, specifically at the trigeminocervical nucleus, where sensory nerve fibers of the descending trigeminal nerve, cranial nerve 5, interact with sensory fibers from the upper cervical roots, C1 through C3. This causes bidirectional transmission of pain. And the next slide here is going to demonstrate an illustration of this proposed convergence center. So on the left, you'll see distribution of the trigeminal nerve, the ophthalmic, the maxillary and mandibular divisions, V1 through V3 there. And then the distribution of the cervical spinal nerve root areas as well, on the back of the occiput and neck. And then you see the nerve pattern of the trigeminal nerve descending towards the neck area, and you see the cervical ganglion with sensory fibers ascending. And you see that dotted line. I can't point to it because I don't have a pointer, but the dotted line basically is where the convergence center is occurring. There are also some studies that say the spinal accessory nerve also contributes in this convergence center also. And if you remember, the spinal accessory nerve innervates the sternocleidomastoid and part of the trapezius. So that's also playing a part into this. So all those sensory nerve fibers are kind of joining in that area. Some of them may be communicating with each other. The messages going back up to the thalamus may be crossed over. So that's the theory behind this. So you can have bidirectional pain again in the occiput, in the head as well as the neck. The anatomy review again, reviewing the three cervical spinal nerves in the innervation. C1 innervates the atlanto-occipital joint, as well as the suboccipital area, as well, and the dura mater. C2, which gives off a branch that everybody knows about, the greater occipital nerve, innervates the occipital area, the articular joint or the facet joint at C1, C2, as well as part of C2, C3. The sensory, the sensation provided to the sternocleidomastoid, trapezius, splenius capitis, and semispinalis capitis as well. And then C3 gives off a branch which forms the lesser occipital nerve, which helps innervate the cervical splenius capitis, longissimus capitis, semispinalis cervicus, and the multifidi. C3 also innervates the C2, C3 facet joint, and that facet joint, as well as the C1, C2 joint, can refer pain to the occiput, as well as the frontotemporal and periorbital regions. So in doing my reading and in seeing some patients in the clinic that may have cervicogenic headaches, it does appear that a more common cause is facet mediated, more so at C2, C3, followed by C1, C2. I'm going to go into the anatomy of the facet and the distribution of facet pain because of this. So this is an image from netterimages.com, and the bottom image, you can see the first three cervical vertebral bodies. You see the superior articular surface, which joins at the occiput, and that is the atlanto-occipital joint. And then to your left, you'll see the C1 body, and then to the right is the C2 in different views, superior and anterior and inferior and posterior. So you can see the articular surfaces that are joining, those are the facet joints. That's what's implicated, just to review the anatomy in some of the cases of cervicogenic headache. The next slide, which many of you may be familiar with, the Dwyer diagram on facet-mediated distribution of pain. So as you can see, the estimated distribution of C2, C3 does involve the posterior occiput, the auricular area, as well as the superior cervical area. C3, C4 also is indicated in that as well. And then I added this in. This is a study done in Australia And the researchers published this in 2007 in Australia, and it's showing the distribution of pain mediated by facet joints. So in this study, they basically had patients that they used the criteria to determine had cervicogenic headaches, and they gave them a diagram to draw out where their pain was. So of course the diagram didn't look like this, but they drew X's and circles around where their pain was located in their head and in their neck. And the researchers performed facet joint injection, facet joint blocks at areas based off of where they thought their pain was originating from. And if it was a positive or a negative result, that was recorded. A nurse was blinded. If the patient had a negative result, another level was trialed. And based off of all those results, these pain maps were developed for estimating where pain from different facets went in a distribution pattern. So I found this interesting because at C1, C2, you can see a percentage of patients, a high percentage of patients also were found to have pain at the top of their head, right? And then at C2, C3, you see a lot of patients seem to have that distribution of pain at the front of their head. So these are from very high cervical facet levels with those types of distribution of pain. Okay, so moving on to how do we diagnose cervicogenic headaches? What's important to evaluate when you see a patient in front of you that you may be suspecting of cervicogenic headaches? A history of trauma is important to get, as we saw on the second slide. 53% may be related to whiplash or trauma injury, so getting that history is important. A personal and family history of arthritis, vasculitis, other type of bony disorders may be important. And then of course functional assessment. I'm a physiatrist, so I'm doing a functional assessment on every patient. How are they moving? Do they use equipment? How they're performing their ADLs? What do they do for work? Do they have difficulty at work? Do they have symptoms? When are they precipitated? Are they able to drive? Are they able to turn their neck and drive? Are they not able to do that? All of those things are important in the history. Differential diagnosis. So this first slide is showing a differential which can include, you can see this in a cervicogenic headache, or you can see it separately. So these are clinical features of cervicogenic headaches which can mimic and or involve other isolated disorders of the neck and can also be seen sometimes in cervicogenic headaches. So cervical myofascial pain is probably one of the most common things I see in the office, including tender muscle points with or without trigger points. Occipital neuralgia, which is described as a burning, shooting pain in the distribution of the greater or lesser occipital nerve, and can be temporarily reduced by blockade of the nerve, preferably image guided. Migraine, I'm not going to get into the different types of migraine, but there's several different types. Tension type headache, which is typically presented in a band-like fashion surrounding the head, frontal or posteriorly. Hemicrania continua, which a lot of patients present with autonomic type symptoms and pain on one side or the other with some unilaterality. C2 spinal nerve compression, which can be caused by subluxation. Sometimes arterial or venous compression can present in addition to occipital or scalp burning. Sometimes you can see patients with tongue sensory symptoms or an excessive eye lacrimation. So just things to look out for. The next slide here is featuring some other headaches or other disorders that can mimic cervicogenic headaches. The ones that are starred are things that you definitely don't want to miss. So intracarotid or vertebral artery dissection, stroke, posterior fossa mass of the brainstem or the cerebellum. Arnold-Chiari malformation, where part of the brain descends through the foramen magnum into the spinal canal. Herniated disc, which can cause radicular symptoms into the arm. AV malformation, spinal tumor, meningitis or encephalitis. These can include systemic symptoms, especially fever and mental status change. Giant cell arteritis, sometimes with facial pain. Some people have visual complaints also with that diagnosis. Rheumatoid arthritis, that disorder is known to be known to cause atlantoaxial subluxation. Subarachnoid hemorrhage, where patients present with the worst headache of their life. That's usually what they complain about. And then the last one here is CSF leak, or also known as a spontaneous intracranial hypotension. A very slow CSF leak can cause a chronic postural headache. So a lot of these headaches are postural, meaning they're alleviated when supine and exacerbated when they are sitting or standing in position. So just keep that in mind also. Physical examination is also equally important in examining these patients. Inspection, alignment, range of motion, posture, palpation of musculature, checking pulses, specialty testing such as upper motor neuron signs, a Sperling's maneuver, Hoffman's, Babinski, and then a good neurologic examination, speech, motor, sensory, coordination, balance, and gait. So there are certain studies here which have some specialty tests in cervicogenic headaches that have been recommended if you suspect a headache. The cervical flexion rotation test, there are a few studies that have shown that this has the greatest accuracy, showing high specificity and sensitivity, specifically in the passive form to be tested. So normal range of cervical flexion and rotation on average is 44 degrees. Those with cervicogenic headaches passively tested, once again, had a 17-degree or less rotation towards the side of their headache compared to patients without headache or patients with migraine with aura. And then another physical exam which can be useful in cervicogenic headache is the passive accessory intervertebral movement test, where the segments are being mobilized to see if they induce pain. The studies have shown segments C1 and C2 are the most common and symptomatic, so that may be useful to do as well. And the next slide is showing the passive flexion rotation test, which we talked about on the previous slide. Another physician has demonstrated in patients with cervicogenic headache a syndrome which he's coined as the upper crossed syndrome, Dr. Jonda, where many of the patients presenting with cervicogenic headaches are presenting with tight suboccipitals and upper trapezius levator scapula musculature, tight pectoralis anteriorly, and then weak cervical flexors as well as weak rhomboids and lower trapezius musculature. So I found that interesting. And definitely going to add that to my physical exam to see if those patients present with that. Also important in the physical examination is palpation for myofascial trigger points. Trigger points in many studies, and I've listed a few here, trigger points in many studies have been shown to lead to cervicogenic headaches. Points specifically in the sternocleidomastoid, upper trapezius, temporalis muscle, or the suboccipital area have led to cervicogenic headaches. 1989, there was a study done where they found that 50% of the headaches could be reproduced by palpating 3 trigger points on the affected side. Another study in 2007, case study where a patient with chronic headaches was found to have sternocleidomastoid trigger points, and after having mobilization and manual therapy for 6 weeks and then 6 months, patient had 70% relief of their cervicogenic headaches. So what was done in that case study was kinesiotaping of the SCM, therapeutic trigger point release with soft tissue mobilization of the SCM, manual therapy, stretching exercises. They even used biofeedback with EMG for the SCM to show that, you know, certain movements help to relax it versus contract it, and then postural education as well. So I found that interesting. 70% relief with just that one muscle, decreasing cervicogenic headaches. Other part of the diagnosis, which may be diagnostic testing, which may be helpful to rule in headaches or rule out other disorders, include imaging. So X-ray, CAT scan, MRI, and then looking at the vasculature. EMG nerve conduction study can also be helpful additionally. And sometimes you do have findings on MRI, CAT scan, or X-ray, which can clue you into a diagnosis. Hey, there is something going on at the neck. There is pathology at the neck, and they have unilaterality to their headache symptoms. Could this be a cervicogenic headache? Laboratory evaluation can also be helpful, especially in those systemic type of disorders. So checking ESR, CRP, which are inflammatory markers, RF is rheumatoid factor, thyroid tests, complete blood cell count, CPK, and even an LP in some cases can help differentiate either other diagnoses. Things not to miss, when to refer to a physician. So if you have focal neurologic findings, vision loss, unilateral weakness, numbness, neurologic symptoms, frequent repetitive loss of balance, history of frequent falls, clonus, Hoffman's, Babinski sign that's new, that wasn't there before, that's you know, something concerning. Papilledema, a sudden onset and severe headache, worsening headache with Valsalva maneuver or change in posture, headache with systemic signs, especially fever, nuchal rigidity or stiff neck. Physiatry referral can also be helpful. If patients that you're seeing that you think could benefit from a myofascial examination and workup, or in need of a topical or oral pharmacologic intervention, could benefit from trigger point injections or myofascial manipulation. If the patient is in need of imaging, is in need of bracing or adaptive equipment, is in need of an EMG, or if you're unsure, you have a patient in front of you, you're not sure, can I use traction? Can I do electrical stimulation? Should I be thinking about ultrasound, heat, ice, whatever you're thinking about? That might be another reason to send to a physiatrist. And then physiatry can be your bridge to other specialties such as neurology, neurosurgery, pain management, sports and spine physicians, and of course the primary care doctors as well. Okay, moving on to treatment. So the mainstay of treatment, and all my reading on this topic includes the physical modes of therapy. So gentle stretching, manual traction, manual manipulation, strengthening, manipulation therapy in combination with exercise, osteopathic manipulation, using craniosacral, strain counterstrain, and muscle energy. All of these are really the mainstays of treatment. Of course, caution needs to be used with any high velocity, low amplitude manipulation, which can lead to arterial disorders, including dissection, stroke. So just presenting some of the evidence again supporting cervical manipulation, mobilization, and exercise here. Study in 2002, which was a large randomized control study in Philadelphia. 200 patients with cervicogenic headaches were treated in 4 different groups: manipulation, exercises, a combination of manipulation and exercise, and a control group. The main outcome, of course, was change in cervicogenic headache frequency, with results showing statistically significant decrease in frequency of headache in both manipulation and the exercise groups at 12 months. Here's more, this is the same article, but just both forms: low load endurance, craniocervical and cervicoscapular exercises, as well as manual therapy, again, are shown to reduce the frequency of headaches. And then I pulled this from an article published in the Journal of Sports Physical Therapy, just an illustration of some of the exercises that could be used specifically in cervicogenic headaches. This is an evidence-based approach to clinical management. So in this diagram, the craniocervical flexion is performed against an elastic TheraBand. Patient begins in protraction and then is led to push against the band with tension. So that's one form of treatment. And then the other is cervical stabilization using a mini ball with resisted scapular retraction. Does anybody use any of these, or does anybody do this with their patients? Okay. I thought so with this audience. Okay, postural training is equally important. I'm always telling patients to visualize their elbows towards their back pocket as resetting their posture immediately. So positioning, their elbows aiming towards their pant back pocket is a way that I, quickly tell patients reset your posture. While you're sitting here, try it. See if your posture resets. It kind of aligns the spine, relaxes some of the muscles. So other techniques that haven't been studied specifically in cervicogenic headaches, but could be useful because they do decrease headaches, especially the episodic tension type headaches. So there's a study in 2016 looking at traction, cervical traction, the McKenzie exercises, as well as cranial rhythmic impulse treatment, a manual form of therapy, and that was useful in reducing both episodic tension headaches, the frequent and infrequent types. So this perhaps could be also useful in cervicogenic headaches as well. And these are techniques that we all use. Electrical stimulation, this is something where a lot more research is also needed, but it may show promise. A study done in 2009, the study size was very little. It was one patient with cervicogenic headaches that had improvement with electrical stimulation. So that study, again, the research needs to be expanded with that specific modality, but showing promise. And then instrument-assisted soft tissue mobilization using the Graston technique, depending on what the cause is, but that can also be useful in myofascial release. One of the articles focused on the self-snag. How many of you have heard of the self-snag? Okay, so the self-snag, it was developed by Brian Mulligan. The concept in the article was a self-snag at the C1, C2, which is a self-sustained natural apophyseal glide. And this study, I'll show you on the next slide what that looks like. This study had 16 participants in the self-snag group who performed 2 repetitions twice daily for 12 months. and resulted in improvement in the cervical flexion and rotation by up to 15 degrees. Remember, normal was around 44 degrees, and also had a reduction of headache symptoms. So I'm going to show you the next slide. The advantage of that self-snag also is once the patient is trained, they can do it at home also versus coming into a therapy session or using certain equipment. So this next slide shows the Mulligan strap, where a force, so the patient is turning towards the right. The force is applied at the C1 level with the strap that goes around the back at that level. And at the same time, the patient is turning the head towards the right and pulling as well. So that's what the self-snag is demonstrated to be. Moving on to pharmacology. So there's a lot of limited evidence specifically in patients with cervicogenic headache. Pregabalin, there was a small study showing pregabalin, which had some benefit at 12 weeks with titrations of up to 450 milligrams daily. I think that was broken up in a BID dosing, but there wasn't, that study looked at the patient also at 4 weeks without much relief. So the dose really had to be titrated up, and the duration was, they needed to stick with it. A lot of patients won't stay with a medication for that long if it's not working. So not sure about pregabalin, but it may be useful. And then there's a lot of other oral medications. I'm not going to go over the different categories. A lot of them are used for migraines and headaches. A lot more studies, again, could be done with specific patients in cervicogenic headache. There may be some use for some of them. Topical agents may also be a good adjunct as well. Psychological and behavioral treatment could also be helpful adjunct. Techniques like biofeedback, relaxation, and cognitive behavioral therapy could be helpful. Again, more research is needed. Trigger point injections of the myofascial spasms, specifically of the muscles that we discussed previously, the sternocleidomastoid, upper trapezius, suboccipital musculature, could be helpful. And then anesthetic blockade, which is listed in the criteria. Both international groups in the first few slides mention anesthetic blockade. Anesthetic blockade can be done with just numbing agents, bupivacaine, lidocaine, xylocaine, or with steroids. This slide really just focuses on the numbing agents only. So I've read in a few studies that there are some benefits with cervicogenic headache reduction with repeated greater occipital nerve blockade. So that could be helpful. And as we know, that nerve branches from the C2 spinal nerve. Also benefit from facet joint injections, which we talked about before also. Rehabilitation and exercise as well as manual manipulation are helpful in conjunction following these blockades. So that's a key point, and may actually prolong the headache reduction frequency. Here's a study done in 2010, or published in 2010, focusing on facet blocks specifically in treatment for cervicogenic headaches. 31 patients met their criteria using the diagnostic criteria for cervicogenic headaches. The blocks were conducted under fluoroscopic guidance, and they were targeting the C1, C2, C2, C3 facet joints, as well as the dorsal rami of C2 and C3, this greater and lesser occipital nerves. And about 90.3% experienced greater than 50% headache relief immediately after the procedure. And then the headache relief was lasting about 21, 22 days. And with a range of anywhere from 1 to 90 days. So that's something that goes along with everything we've talked about, the facet-mediated pain. And then sometimes these injections are coupled with glucocorticoids. Dr. Slipman, I believe he's a physiatrist actually, he did a retrospective study in patients with cervicogenic headaches that underwent a C2 through C3 facet joint intra-articular injection with steroids, showing that 61% of the patients had reduction of headache frequency at 19 months. And then there was another study with injections at the atlantoaxial joint, again, C1, C2, showing statistically significant reduction in pain scores initially, but not lasting greater than that 6 months. Radiofrequency neurotomy or ablation can also be helpful, specifically if the blockade was known to cause positive results. Again, more studies need to be done here. It's a risky procedure, especially higher in the cervical spine also, but it can be helpful. Surgery. Now, surgery depends on if there's a lesion seen in the cervical spine. So it can be helpful in reducing headaches in some cases. This was tough for me to find also, but certain studies are showing that if all other treatment measures fail and a lesion is seen that they think is causing the cervicogenic headache from the cervical spine, sometimes it can be helpful. So decompressing the greater occipital nerve sometimes can be helpful. In patients with severe osteoarthritis of the joints of the spine, a fusion or arthrodesis may be indicated. Actually, those patients in that study had very good results with reduction of their headaches as well. And then what really needs more research, and this is real high risk also with some of the levels we're talking about, C1 through C3 is a spinal stimulator implantation. And then, of course, when you're talking surgery, worsening of pain is also something. Worsening of headaches can also occur, so that's something to be careful about also. All right, we're coming to a close at this talk here. Key points. So cervicogenic headaches are secondary headaches caused by disorders of the cervical spine. The headache must be present and coincide with the cervical spine pathology appearing too. And that may be clinically diagnosed or imaging-based diagnosed or a combination of both. The diagnosis is very challenging. Going through this presentation, you can see the diagnoses could be related to a headache or can be standing alone. So whether patients have headache related to migraine or other types of headaches, and then having a separate standalone neck issue, that's a possibility, or are they related? That's another possibility. It's a challenging diagnosis to make, but the diagnostic blocks can really help in the diagnosis if you're really suspecting it, because I think most of these cases can be related to that facet-mediated pain. The mainstay of treatment in the current research is physical therapy, physical motive therapy, and rehabilitation. And then more invasive treatments require further research. They're very small studies, just not enough evidence for us to really know if they're going to be helpful or not. So that's really the end of my talk. I did look at several different research studies, which are in the references. And if any of you have any questions, comments, or concerns, feel free to reach out to me at any point in time. Are there any questions currently in the room or by Skype? Okay, that's fine. Okay, no problem. We'll wait to see what the questions are. So how many of you treat patients with headache? Yeah, about half of you, maybe a little bit, maybe 3/4 of you. And how many people do you see with neck pain, either together or separately with those headaches? Quite a bit, right? Yeah, so the diagnosis can, should cross your mind, and if you're thinking about it and if you think that these patients might have headaches more related to their neck pain, cervicogenic headaches as a diagnosis should be thought about, and referral at that point can be made, because all those medications, they may not be working for headaches specifically. So there's one question here, and it says, in my experience, how closely does this correlate with cervicogenic dizziness? So cervicogenic dizziness and cervicogenic headaches, in my experience, completely different phenomenon. Some patients do, in the criteria, have symptoms of, do I have to type the? No. Okay, I'm just making sure. I'm like, do I have to type this? Some patients do have symptoms that may correlate with that, but I didn't read anywhere that they're the same thing. So cervicogenic dizziness may be a completely different diagnosis altogether. But good question. There's actually articles that separate the two, so they're two separate diagnoses as far as I know. Although I'm not very, very experienced in this. I'm learning just like all of you are about this. I do see a lot of patients with myofascial pain of the neck that also have headaches and are treated with the headache team here with migraines. So this topic was of interest to me because I do see a lot of patients with neck symptoms, and I'm trying to figure out if some of them have cervicogenic headaches and what to do about it, how to guide their therapy, their physical modes of therapy, how to guide their rehabilitation, and then if they need referral, do they need referral to a pain management specialist? Do they need facet-mediated anesthetic blocks? Do they need further investigation with that? Here's another question. Any other comments in the room? No? Okay.
Real quick, while they're typing, I'll just say this is going to be the last lecture that's here at 8th Avenue. After this, they'll be at the Ed Center at the hospital for the neuro lectures.
Yeah. Okay, another question. How often do you utilize grade 5 mobilizations to the upper C-spine? Not often at all. I do some manual release techniques in the office and do trigger point injections, but I don't typically do a lot of mobilization in the office. There's not enough time for that. I do refer to you guys if I feel like it's safe to do mobilizations, and I do include that in my prescriptions. I typically do write out restrictions and things that I'd like to see done if I feel like it's safe. Sometimes I'll image the patients if I know that they could benefit from mobilization, just to make sure they don't have any other pathology going on. But I don't have too much experience doing a lot of mobilization of the upper cervical spine myself. Yep, you're welcome. Josh is typing. Okay, thank you. Thank you all for your attention, and I hope to see you all soon.
All right. Thanks, Dr.
All right.
Make sure everybody is signed in, and for New Jersey, make sure you're also signing out. And then the certificates are over there next to the sign-in sheets. And anybody online, make sure you email to get the questions to get credit. Thanks.